Dr. Hahn and to the SoCal GI Society for allowing me to speak at this symposium. And I'm going to present two abstracts on PSC and two abstracts on PBC, which will be a combination of phase 2 clinical trials as well as multicenter cohort studies. So first I'm going to start with PSC. The first study I'm going to discuss is with regards to the FXR agonist GS9674 in the treatment of primarily sclerosing cholangitis as part of a phase 2 trial. So the farnesoid X receptor, or FXR, is a key regulator of bile acid homeostasis, and this is disrupted in the setting of PSC. Activation of FXR may have some positive downstream effects for the liver, which includes reduction in inflammation, bile acid accumulation, and development of fibrosis. And one of the medications we use in our PBC patients, which is obeticholic acid, actually induces this same mechanism of action. GS9674 is an oral molecule, which is an FXR agonist. So this study was a phase 2 study to assess both dosing, safety, and efficacy of GS9674. This was a randomized placebo-controlled study where patients were randomized to receive either placebo, GS9674 at 30 milligrams, or at 100 milligrams dosing. And the primary outcome was looking at improvement in liver biochemistry, primarily alkaline phosphatase. The inclusion criteria was a diagnosis of PSC based on cholangiogram, so small duct PSC was essentially excluded. Patients were also non-cirrhotic as based on FibroTest, and patients had to have a serum alkaline phosphatase level of greater than 1.67 times, upper limit of normal, but also had to have a bilirubin level of less than 2 times the upper limit of normal. So those with severe cholestasis were excluded from the study. Again, efficacy was assessed primarily with liver biochemistries, but they also assessed markers of fibrosis as well as bile acid homeostasis. And these are some of the baseline characteristics of the three study groups. The majority of the patients were male and younger males in the late 30s or mid-40s. Then the median serum alkaline phosphatase level ranged from 344 to 380. Serum bilirubin level was overall within normal limits. And ursodiol therapy was not considered an exclusion criteria, and approximately 50% of patients in each arm were taking ursodiol. So what did the study show? This slide here, I'd like to focus on this graph, which is the reduction in alkaline phosphatase after 12 weeks of treatment. If we look at the 100 milligram arm, there was a reduction in alkaline phosphatase by 73 points at week 12, and this was statistically significant as compared to placebo, where there was actually a mild increase in alkaline phosphatase level. If we look at the lower dosage of 30 milligrams, there was a reduction in alkaline phosphatase as well by 21 points. However, this was not statistically significant. So what you can see is that there was a dose-dependent reduction with regards to improvement in alkaline phosphatase. In this slide, we are looking at the improvement in alkaline phosphatase stratified by whether the patient was taking ursodiol. If you focus on the dark green bar, this looks at the 100 milligram dosage, which is where the greatest efficacy was seen. And among the patients who received 100 milligrams of GS9674, the mean percentage change in alkaline phosphatase was approximately 20%, and that was regardless of whether the patient was or was not receiving ursodiol. Finally, this slide here looks at a variety of parameters among patients who were alkaline phosphatase responders. So these are patients who received the medication and had an improvement in alkaline phosphatase greater than 25% from baseline. And among these other biomarkers, you can see that among the alkaline phosphatase responders, which is the light blue bar here, the ALT, there was a reduction. It was not statistically significant, but there was a reduction. There was also reductions in total bile acid levels, as well as CRP levels. These were not statistically significant, though numerically they do appear to be notable, and in larger studies they may play out to have statistical significance. With regards to adverse events, the percentage of adverse events was similar among all three groups, regardless of dosage or receiving placebo. And more interestingly is if we look at Perititis, which is one of the challenges we have with our patients with cholestatic liver disease, the percentage of patients who had Perititis was overall similar among the three groups, and particularly if we look at grade 2 and grade 3 Perititis, it seems like there was actually a greater percentage of patients with grade 2 Perititis among the patients who received placebo. Grade 3 Perititis was 9 to 10% among the three groups. So in summary, GS9674 is an FXR agonist, which does have a dose-dependent improvement in alkaline phosphatase, as well as reductions in other markers of cholestasis, including bile acid homeostasis, inflammation, and possibly fibrosis. The alkaline phosphatase response was independent of whether the patients received ursodiol, and overall tolerability seemed to be good without worsening of Perititis, and therefore further study may be done for this molecule. So next I want to look at a study from a multicenter consortium with regards to helping to prognosticate PSC patients. One of the challenges we have, beyond the fact that there are no medical treatments which have been shown to be effective for PSC, is that we also don't have any great means of determining prognosis. And I know Dr. Bolus did mention a number of models which are available. Now, all patients with PSC, or I would say the majority of patients with PSC, require a cholangiogram for diagnosis, and therefore nearly all of them will have had an MRI, MRCP as part of their initial diagnosis. So in 2014, Ruiz and her group from Paris had developed a radiologic criteria based on baseline MRI, MRCP to determine if the patient with PSC would have radiologic progression of their disease over a period of 4 years of follow-up. And radiologic progression of the disease was defined as worsening of any of the parameters. They came up with two risk scores known as the Analia scores. The first one was without gadolinium contrast, meaning a non-contrast enhanced MRI, MRCP. And they had three parameters in their scoring system. This included intrahepatic biliary ductal dilatation, dysmorphia of the liver. Dysmorphia was determined as a combination of caudate lobe hypertrophy or right or left lobe atrophy, and then the presence of portal hypertension. The score went from 0 to 5, and a cutoff of greater than 2 was indicative of high risk of radiologic progression. The second score was the Analia score with gadolinium contrast. So this was a simpler score, but required the use of contrast. And based on the combination of dysmorphia along with liver parenchymal enhancement as compared to biliary enhancement, this also predicted the risk of radiologic progression of disease. And this was a simpler scoring system from 0 to 2. A cutoff of greater than 1 was indicative of risk of radiologic progression. So the purpose of this current study was to determine whether these scoring systems actually could predict the likelihood of clinical outcomes. And this was a multicenter study with a derivation cohort of 119 patients and then a validation cohort of an additional 119 patients throughout several centers in Europe and Canada. All patients had large duct PSC, and all patients were above the age of 18. And with regards to the events that were collected during follow-up, this included liver decompensation, transplantation, and death. These were the baseline characteristics of both the derivation and the validation cohort. The majority of patients were younger males. The majority of patients had both intra and extrahepatic ductal PSC, around 70%. And the mean alkaline phosphatase ranged from 1.6 to 1.9 times the upper limit of normal. And with regards to the overall outcomes found in each group, there was about 30 to 35 outcomes in each group, the majority of which were found to be decompensation of cirrhosis. So what did this study find? So with regards to the first score, the Analia score without gadolinium, using a cutoff of 2, they found that there was a good prediction of the development of clinical outcomes with a sensitivity of 85%, specificity of 77%. So with a high sensitivity, that indicates that patients who had a cutoff of less than 2 had a lower risk of developing clinical symptoms. And in their external cohort, they were able to validate these findings. And this was done through over 10 years of follow-up time. Now with the score, the Analia score with gadolinium, they were able to also find a high sensitivity. However, the specificity was lower. It was 75% in the score without gadolinium and 68% with gadolinium. But again, the sensitivity remained at 85%. And again, they were able to validate these findings in the external cohort. This group also looked at the Analia scores with regards to development of clinical outcomes and compared them to serum biochemistries to determine which one was a stronger predictor of poor clinical outcomes. This is a multivariable Cox regression analysis which was adjusted for a number of parameters, but it's focusing on both the Analia score with gadolinium as well as total bilirubin. 17 micromoles per liter correlates to approximately 1 milligram per deciliter, so basically an abnormal bilirubin. And what was found was that the Analia score did have a much stronger hazard ratio to predict clinical outcomes as compared to an abnormal bilirubin level. In the second regression analysis, looking at the score with gadolinium as compared to alkaline phosphatase above 2 times the upper limit of normal, similarly, the hazard ratio was much stronger with regards to the Analia score. So in conclusion, there have been 2 MRI risk scores which have been established previously to predict radiologic progression of PSC. These 2 scores have been validated in an external cohort to predict clinical outcomes, and my opinion is that these scores may be clinically useful to follow patients. The majority of your patients will have already had an MRI MRCP such that you can determine these scores, but I do think further study is needed. One of the limitations is that they did not account for development of intrahepatic or cholangiocarcinoma. So now we're going to switch gears to PBC. The first study is looking at a phase 2 study of seladelpar, which Dr. Bolas touched upon, in treatment of PBC over a 52-week time period. So as all of you know, ursodiol is the first-line treatment for primary biliary cholangitis. However, approximately 40% of patients may not respond to treatment, and there is an FDA-approved second-line therapy. However, response may not even occur in patients who received second-line therapy. So there's still an unmet need in terms of additional treatments for primary biliary cholangitis. So seladelpar is a PPAR delta agonist, and agonism of the PPAR delta system may have further downstream effects in terms of improving liver physiology. That includes reduction in bile acid accumulation and the possibility as well of reduction in inflammation and fibrosis. So this was an open-label dose-ranging study. It was not placebo-controlled, but it was designed to compare the efficacy of seladelpar at 10 milligrams versus 5 milligrams with the option to increase to 10 milligrams by week 12. All patients were either on a stable dose of ursodiol and found to be refractory to ursodiol, or they were intolerant to ursodiol. In addition, all patients had an alkaline phosphatase greater than 1.67 times the upper limit of normal, as well as a bilirubin less than 2 times the upper limit of normal. So very similar to the POISE study, which looked at obeticholic acid. The primary endpoint was the percentage change in improvement in alkaline phosphatase. The secondary endpoints included what was considered a response to treatment. Response to treatment specifically defined as a reduction in alkaline phosphatase by 15%, as well as less than 1.67 times the upper limit of normal after treatment, and normalization of bilirubin. These are the demographic characteristics of the study groups. The majority of the patients were female, and the majority of patients were middle-aged. And so what did the study show? In comparing both the 5 to 10 milligram dosage as well as a 10 milligram dosage, there was an overall 45% reduction in alkaline phosphatase from baseline. So there did appear to be good efficacy for this medication. Now, if we look in more detail with regards to a combination of complete response as well as alkaline phosphatase normalization, in this graph here, we're looking at complete response, which, as I mentioned before, was a combination of reduction in alkaline phosphatase as well as normalization of bilirubin. And what was found was that 59% of patients in the 5 milligram dosage, which was then up-titrated, had a complete response, and 71% of patients in the 10 milligram dosage starting from baseline had a complete response. When we look at alkaline phosphatase normalization, which is ultimately the goal a lot of us want to achieve in our patients, that ranged from 24 to 29% among patients receiving the medication. Now, what's interesting is if you look at serum cholesterol markers, there was no worsening of cholesterol. So in fact, Among patients who received the medication, there was actually a reduction in LDL in both study arms, ranging from 13 to 21%, and an increase in HDL, which was not significant, but there was not a lowering of HDL, which could be seen in other medications. Now, what I also found most interesting was that a number of these patients had pruritus at baseline. And this study examined improvement in pruritus using the visual analog scale, which is a survey validated to assess pruritus. And what was found, particularly in the patients who received the 10 milligram dose, was that there was a significant reduction in pruritus as determined by the VAS. And that was found to be around 66% of patients who had itch at baseline had a reduction in VAS who received the 10 milligram dosage. With regards to adverse events, those were similar between both the 5 to 10 milligram arm as well as the 10 milligram arm. So in summary, seladelpar did have an anti-cholestatic effect, and this was maintained over a 52-week period of time, and up to 71% of patients did achieve one of the study endpoints of response to treatment. The medication was well tolerated and not associated with pruritus, with the possibility of potentially even improving pruritus. Okay, the final study I'm going to go through is a multicenter study which is looking at a combination of ursodiol treatment and serum bilirubin levels in the treatment of PBC. So this is from the FOLD Consortium, which is a multicenter consortium throughout the United States, of which they've collected data on approximately 4,200 patients with PBC. The objective of the study was to look at the treatment effect of ursodiol as stratified by a number of different groups based on a combination of gender, ethnicity, and cirrhosis status, and also to look at the effect of ursodiol in improving mortality with regards to baseline serum bilirubin levels. The observation period was approximately 12 years, and these are the variables collected. Of note, they grouped alkaline phosphatase based on the upper limit of normal and similarly grouped albumin based on lower limit of normal. So this rather busy slide here, I just want you to get one point across, which is that regardless of ethnicity or gender or cirrhosis status, in the vast majority of groups, ursodiol improved mortality. And that should be obvious to all of us. However, that's the point of this slide, is that in nearly every group, ursodiol reduced mortality. Now, the only group where there actually was not seen to be a benefit was this group here, which was women with cirrhosis who had an albumin level below the lower limit of normal. And among these patients, again, the hazard ratio indicated that there was not benefit, but also not harm. Now, that said, there is no reason not to treat this group. This group of patients should absolutely be treated. Perhaps this information, though, can help to prognosticate these patients. In this next slide, this looks at both race and gender, but also looks at baseline serum biochemistries. And here's what I'm going to focus on. The first is looking at the different races, and they looked at both African Americans, whites, and then this group here is a combination of Asians, Native Indians, and Pacific Islanders. And what I want you to get here is comparing African Americans to Caucasians. Among the groups that were untreated between these two ethnicities, African Americans did significantly worse compared to Caucasians if they were not treated. That effect with regards to mortality was attenuated when the patients were treated. So the point is to note that African Americans, if they are untreated, may do worse than other ethnicities, and so they certainly should receive treatment with a positive diagnosis. Secondly, this study looked at serum bilirubin levels. Now, they used a bilirubin level of 0.4 as the upper limit of normal. And what was found is that even among patients who were treated with ursodiol, there was a stepwise increase in mortality with an increase in baseline serum bilirubin level. And this included even bilirubin levels which are considered within normal limits. So if you look at the first group here, this was as compared to 0 to 0.4, a bilirubin level of 0.4 to 0.7 did have a mild increase in overall mortality, again, regardless of ursodiol treatment. And that continued stepwise until you reached a bilirubin of approximately 1.5 to 2, and at that point, the mortality seemed to have plateaued. So the point here is that patients with an elevated bilirubin should absolutely be treated with ursodiol unless there's a reason for intolerance, but to keep in mind the importance of the bilirubin in prognostication and to consider that if a second-line treatment is needed. So in conclusion, from this study, The treatment with ursodiol has been determined to be beneficial among nearly all patient groups. There may be a lack of benefit among patients who are female, Caucasian, and cirrhotic with a low albumin. So a very specific group may have a lack of benefit. Again, no reason not to treat them. The mortality does increase among African Americans compared to Caucasians if there's a lack of ursodiol treatment. And keep note of increasing bilirubin levels do correlate with increased mortality. And to make sure that even if a patient has a normal alkaline phosphatase level and is treated with ursodiol, that an elevation in bilirubin could indicate poor prognosis. Thank you for your attention.